Hello, everybody. Welcome to our webinar. We're going to let people funnel into the room, and we'll start in like a minute or so. Thanks for joining. Okay, the number of attendees is slowing down, so let's start our webinar today. Thank you all for joining us. This webinar, which is sponsored today by the California Immunization Coalition and the American Academy of Pediatrics in California. The topic for today is AAP's evidence-based childhood immunization schedule, what the experts say. This has been a very confusing time for all of us in medicine, especially in pediatric medicine, and we're happy that you're joining us today to shed some light on what the current recommendations are. So just some housekeeping. All the lines are muted during the program. We will have time for questions and answers. There's a box at the lower right corner, the Q&A box, so please utilize that for communication. We will monitor that the entire webinar. And then, as always, this webinar will be recorded and posted to the California Immunization Coalition website, as well as our CIC YouTube page. Dr. Pannaraj and I have done for almost 5 years now a few dozen of these conversations with experts about topics in immunizations and infectious diseases, and you could find all of those on our YouTube page from the past. I am your moderator today. My name is Dr. Eric Ball. I am a primary care pediatrician at the CHOC Primary Care Network in Orange County, California. I'm currently the chair of the American Academy of Pediatrics in California, and I am a board member of the California Immunization Coalition. And our speaker today is Dr. Pia Pannaraj. Dr. Pannaraj is a professor of pediatrics at the University of California, San Diego, and an infectious disease specialist at Rady Children's Hospital. She also is currently the president of the California Immunization Coalition. She serves also as the director of the Pediatric Immunization Advancement Laboratory at UCSD. Her global research focuses on maternal and infant vaccinations. She also serves as the American Academy of Pediatrics expert panel for Global Immunization Advocacy Initiative, for which he's advised national pediatric societies in many countries. And importantly for today's topic, she also serves on the AAP Redbook committee and is part of the American Academy of Pediatrics committee, which puts out immunization recommendations every year. She completed her infectious disease fellowship at Baylor College of Medicine, her master's of public health at the University of Texas Health Center, medical school and residency training at UCSD, and undergrad in economics and biology from the University of Chicago. And with that, I'm going to pass this on to Dr. Pannaraj, and thanks for joining us and talking to us about AAP evidence-based childhood immunization schedules.
Perfect. Thank you, Eric. So it has been a fun several years of us doing this immunization emerging conversations together. So today I'm going to talk about the AAP schedule that was just released. But even before that, here we go. Just so that you all know, I don't have any disclosures. So I'm going to talk about the current attack on vaccines so that you sort of understand current events leading up to today. And then review the trusted resources for ensuring that vaccine use in the United States remains anchored in science. And then we'll go through the updates and the rationale on the newly released AAP immunization schedule. So just very briefly, you all are here, so you all know why we care about immunization. So I'm just going to talk about just one disease, measles, because it's on the rise. It's very much a current event. And you could see our numbers here over the past several decades. And we're at a high now, 1,375 cases reported in the United States. We think this is just this year, and we think this is very much an underreporting, so that the case numbers are actually much higher. And this is the highest that it's been since the early 90s. And you could see that about, if you look at the numbers there on the right side, about 50% of those, or actually a little bit more, are children, and 92% of those are unvaccinated or with vaccine status unknown. Most of those unknown are actually unvaccinated or incompletely vaccinated. And so measles is highly contagious. It spreads through the air when somebody coughs or sneezes. And when there's somebody with measles in the room, usually 9 out of 10 people around them will become infected. And it doesn't even have to be that even while they're in the room, even if they leave the room for the next several hours, anybody walking into that room can become infected. And most people who have acquired measles in the United States actually either traveled internationally or were around somebody who traveled internationally. So this is a reminder to vaccinate anybody that you know is traveling, particularly if they're incomplete on their vaccines, or if they're between 6 to 12 months of age where they haven't received their first measles dose yet, they should get that. Or if they're older but haven't received their second measles booster yet, they can also get that. But I also want to remind you that this year we had quite a few measles cases happening in the United States because there was an outbreak in a under-immunized area. And so because of that, we have to keep that in mind, that these diseases that we've prevented can come back at any time. This is really cool wastewater surveillance, where they're actually, just like it sounds, surveilling the wastewater. On the right-hand side there, you could see these are all of the different diseases that we've been surveilling for. And just beginning this year, measles was added to that list. And so you could see here, I think you all can see my pointer, hopefully. So here we have some measles detections associated with known cases, meaning that the index case presented to care, and we had, public health was able to do contact tracing. But you have a couple of detections here that are not explained by known cases. And so that's a little bit scary. That means that there is some measles around that we may not know about, and therefore that means that anyone that's not vaccinated could be at risk. And the problem with so the problem with measles are all the complications that come. So those first couple of things there, otitis media, pneumonia, diarrhea, these are common in children. But what is really concerning are things like acute encephalitis that occurs 1 in every 1,000 cases, death 1 to 3 in every 1,000 cases, and then something called SSPE, or subacute sclerosing panencephalitis. This is where you have a child, usually but under 2 years of age or 2 years and younger, and they get measles, and it seems like they recover just fine, and they go back to being normal, going to school and doing all their normal things. And then 7 to 11 years later, after the infection, they start to lose their developmental milestones. They do poorly in school, and then it just slowly progresses from there. And it's a degenerative disease, and there's no cure. And so we've actually seen this in the United States quite more often than we want to. It has been mostly from kids who were born in other countries, and endemic countries, got measles there, and then immigrated to the United States. But once they have SSP, there's nothing, it's just degenerative and downhill from there, until they lose pretty much all function to walk or talk or do anything normally. And then there's something called immune amnesia. And this is where your body, after a measles infection, forgets everything, every pathogen that you've ever seen before. And so you could develop any of those diseases again, including vaccine preventable diseases. You even forget those, the immunity that you had to vaccines. And so the problem with immunizations for measles is that you need such a high herd immunity goal, and the goal is 95%, which seems great because in California, we're at 96.2%. And this was a map from the New York Times, and unfortunately, I don't have here the whole of California, but you can imagine, even just by looking at these two counties, that there are some pockets there in red, just pockets of under-immunized communities. And those are the pockets that are at highest risk. And that's what happened in Texas. So even though most of Texas had pretty good immunization levels, the outbreak began in one of those communities with low vaccination rates. So we're here at risk also in California. So what's going on right now? I'm starting with this picture. This was very, very sad, only about 2 weeks ago, where a person who was dissatisfied with COVID vaccine shot over 200 rounds, or 200 rounds hit the CDC. And you could see there in the picture multiple bullet holes in the windows. And one person died during that shooting. And, and these are people that were doing their job, basically. And so how did we get here? First, let me go over what is normal, what normally happens in the whole process of immunizations and how those immunizations get approved. So first we start with clinical trials or real world data. And that is reviewed by a committee called FAAP. It's part of the FDA. And when they're looking at all of this data, one of the main things they're looking at is whether or not the vaccine is safe. That's number one. Safe vaccine safety. And then once it's determined that it's safe, then they're looking at effectiveness. So safe and effectiveness are the two main things. And then the FDA, based on that information, grants approval or grants the licensure for the vaccine. And then ACIP then reviews all of that and determines who should be vaccinated. Once ACIP has their meeting, there's usually scheduled meetings throughout the year, and they make a recommendation, then the CDC director signs off, usually within a day or two. The insurance then determines coverage, and then there's public access. And ACIP members, at least for the last 60 plus years, have included experts who are trained in vaccinology, in immunology, pediatrics, internal medicine, and there's also somebody on there representing the consumers. And at all of their meetings, they usually also have non-voting representatives that are from various healthcare organizations and federal agencies. So healthcare organizations such as the American Academy of Pediatrics or the American Academy of Family Medicine, ACOG, the obstetrics and gynecology, just as some examples. And everybody, all voting members must declare conflicts of interest. And the process for getting on ACIP, it's not easy. That some of the application process can take up to 2 years. And some of that is vetting all of those conflicts of interest to make sure that there's no bias. When ACIP meets, they're reviewing. So remember, by the time ACIP meets, the FDA has already granted approval of a particular vaccine. Then ACIP meets and they're looking for, they're reviewing additional data. So they're looking at the magnitude of the public health problem. And would that new vaccine, if put into the schedule, would that actually help the population that's most affected by the disease? So with that, they might look at the different ages, what's the safety and efficacy in children, for example, for those of you who are pediatricians on the call, or they might look at the elderly. And so they're looking at they're much more specific. They're being much more specific than the FDA. They review benefits and harm. They'll look at cost effectiveness. And then with that, they'll also determine what is how likely is the vaccine going to be accepted by the public? What's the feasibility of actually rolling out the recommendation, and how do they make it feasible? So sometimes the recommendation is adapted to make sure that it's most feasible for rollout. And very importantly, they want to make sure that the recommendation allows it to be equitable for everybody. And so these members, it takes a significant understanding, a very deep understanding of not just how to evaluate the clinical data and the clinical trials, but also to understand the community and economics and how to actually roll out these vaccines. So what's different this year in 2025? So one of the first things, actually a lot of things have happened. I've had to cut down my slides quite a bit just to focus in. But unfortunately, so back in February of this year, we had the ACIP meeting, the first one scheduled after the first one scheduled of this year. Basically, it was postponed. And at the time, we thought, okay, is this just a delay or is it a foretelling of what's to come? And so at this time, the American Academy of Pediatrics and many of the other organizations, the ID Society of America and several others, started to prepare. Okay, this is maybe this isn't going to work out. Maybe we need to get ready just in case we need to step up. And so that was the start in February. And then since then, so in April, the meeting that was supposed to be scheduled in February that actually took place in April, that was a seemingly normal meeting in that all the original ACIP members were still there. The data was being presented by the CDC. Recommendations were made. What was a little bit odd was that the next, usually, as I mentioned earlier, the recommendations only take a day or two before they're approved. But in this case, there were 3 recommendations made, and the last one was not actually signed off until the end of June. So when the HHS actually signed off on those recommendations. Then in May 27th, there was an announcement on X for removing COVID-19 vaccine recommendations for healthy pregnant persons and for all children. And so that was announced by HHS and the Health and Human Services. And so that stirred up a lot of press. But then interestingly, then the CDC came out and put out different vaccination recommendations. And so they said shared decision-making between the provider and the families, and that's what's on the CDC schedule. So there's a lot of confusion at that time. And of course, unfortunately, none of this is based on any transparent data. So it lacked the normal process that takes place at the CDC. All of the discussion, the public discussion that the ACIP members usually, will discuss. It's all televised on, you can watch it live on YouTube. Some people could be there in person. And so that transparent presentation of data, review of the data, the decision-making process, the vote, none of that actually happened in this case. And then on June 9th, there was removal of all of the 17 ACIP members. So again, those were all those experts in vaccinology, immunology, pediatrics, internal medicine. So all of them were removed. They just received basically an email that said, thank you for your service. You're no longer needed. And then only 3 days later, they announced 8 new ACIP members. One of those eventually dropped, or one of those dropped right before the meeting took place. But so just a couple of days, new ACIP members, that process, that almost 2 years process for reviewing applications and making sure there's no conflicts, all of that, none of that happened, at least not that we are made aware of. And then on June 25th, 26th, the ACIP meeting happened with the now 7 new members after one person dropped. And we could see there was a lot of confusion at that meeting. And before I talk about that, I'll just note that even, one of the reasons that the HHS felt then they dropped all of the 17 members of ACIP was they said, well, there's a lot of conflicts of interest, even though they had already undergone all of the process to make sure that there were no conflicts. But of the new members, there are some, what seems like conflicts of interest. So there was somebody who served as an expert witness against Merck's HPV vaccines. There are several people who are anti-COVID-19 mitigation measures, including vaccines, who had written articles for the press, published articles on this. Folks that are anti-mRNA vaccines. Interestingly, there is somebody who was previous recipient of funds from Pfizer, AstraZeneca, and Roche. And this, they weren't receiving current funds, they were past funds, but that was one of the reasons cited for removing the original members. So in this case, it didn't seem to apply. And then there's somebody who's a board member of the National Vaccine Information Center, which was formerly called the Dissatisfied Parents Together. And this organization receives lots and lots of money being donated to promote vaccine misinformation, mostly around vaccines and neurological diseases. So it seems like that all of that are potential conflicts of interest. So that meeting happened in June, that first ACIP meeting with the new roster in place. And there was a lot of confusion in that meeting. A lot of it, these were the new folks in place. They had expertise in their own areas, but none of them had expertise with regards to vaccines. There were new work groups that were announced. They were going to, or they want to look at cumulative effects of recommended vaccination schedule and vaccines that haven't been reviewed in over 7 years. Basically, the ones that we know are extremely safe because they've been in use for many, many decades. They want to re-review. So the whole process, especially with all of their confusion and unfortunately their lack of expertise in this area, really is making the distrust in the process amongst the public even worse. And so this is all very concerning. And then in late July, the CDC cut experts out of the panel. So as you recall, there are those non-voting experts that usually attend all of the meetings and help in that decision-making process, and that they contribute their expertise. And so some of those cut all of those cut are listed there in blue. And you could see the AAP is one of those, along with AAFP, Society of America. So, and I was a liaison to 2 of the work groups. So I also received that email that said, thank you for your service. We don't need you anymore. And so without those, it's just additional expertise of people who, or groups who are very aware of their particular populations, such as pediatrics or geriatrics, for example. Then more recently, in early August, NIH canceled mRNA vaccine contracts. This is millions, nearly billions of dollars, citing lack of public trust. More recently, or actually maybe on the same day, there was a report that suggests that the FDA might not reauthorize Pfizer's COVID vaccine for young kids. This would definitely affect This is for ages 6 months to 4 years, and this would definitely affect the COVID vaccine supply. Moderna has been approved, has received FDA approval, but it is for anyone with who is at high risk of complications from developing COVID. So these are all things that are very concerning. So where do we go from here? What do we do? There are a lot of challenges with replacing the ACIP. ACIP had a budget of about $2 million. They had 9 full-time employees and the support of hundreds of CDC scientists, and as well as volunteer external partners. So together, between the CDC scientists and those external partners, there's expertise in disease pathogenesis, epidemiology, study design, so that they can really review all of those studies to make sure that they are rigorous and unbiased. They and any time before each meeting, there's many months of preparation, of reviewing the data and vetting the data before they're presented at the meeting. So something like this, it's very hard to replace. It's hard for any of the individual societies to replace this kind of function. The other area that the CDC supervises is the all of the data gathering for any vaccine adverse events that happens after licensure and after rolling it out to the public, such as VAERS. That's also the vaccine safety monitoring system, and so that's also something that had been in place by the CDC. And it's really important to have unified guidance. So one of the concerns about having all of the different societies making their own recommendations is that there's potential for conflicting messages. There's confusion for providers and for the public, and you risk having vaccine administration errors. We already risk further erosion of what's been damaged, the public trust that's already been damaged. And that leads to more misinformation and decreased uptake of vaccines. And these cohesive set of recommendations are important not just for the providers, but also for state and local public health, pharmacies, insurance companies, and for the general public overall. So, and then also the vaccines for vulnerable populations are in peril. So not only not the private insurance companies, they don't know what to follow, but the Vaccines for Children's program, which covers 50% of children in the United States, is something that it's part of the federal it's administered by the federal government. And so ACIP, when they vote for a new recommendation, they also vote to have that vaccine available in the Vaccines for Children's program. And so if we don't have that, then there's a lot of questions as to what will happen with VFC, and will VFC cover, additional vaccines that are no longer in the immunization schedule. The Veterans Health Administration also relies on funding from the federal government. And then many state laws are linked to ACIP recommendations, including public health agencies and pharmacies, and that affects all states throughout the United States, but including here in California. And there's been a review of looking to see which of our guidance here in California are linked to ACIP, and what and as well as for pharmacies, and what needs to be done about that. Do we need to submit amendments to bills or change the laws so that it's not just ACIP, but also all of other experts as well? And the California Immunization Coalition has been involved in some of that. So that was sort of all the bad news. But here, the thing is that the tides are turning. So we, the medical societies in July, and all the societies listed there, got together and actually sued Kennedy and HHS over the COVID vaccine advice because it was counter to scientific evidence, and there was none of that transparent review process that took place, unlike previous vaccine recommendations. There is this vaccine integrity project that's out of the University of Minnesota and CIDRAP. And their goal, this was launched in April 2025, their goal is to safeguard vaccine use in the US to make sure it stays grounded in the best available science. And they are implementing rapid response communication and developing and disseminating evidence, the evidence base for immunization recommendations and clinical considerations. And they're helping all of the medical societies for continued collaboration and visibility. In fact, just last week, they completed and publicly discussed a review of safety and efficacy of all respiratory virus vaccines. And so they had gathered 24 experts in ID and epidemiology from academic institutions, screened them to make sure there was no conflict of interest. And that group screened over 16,000 abstracts, reviewed, 1,400 full text articles published in the last 1 to 2 seasons. And basically what they did was they took all the data since the last time the CDC did this, or the ACIP did this for their meetings. Because that's what was missing, is that, even if the individual societies could make decisions, they needed help with reviewing all of the data. And you could see reviewing 16,000 abstracts, that's not an easy task. So they got together, they presented this data that was then finally detailed. They did detailed data extraction from 590 papers, and that was presented last week. And basically, and that YouTube link is there if anybody wants to go and listen to it. This is what they reviewed. They looked specifically at COVID, RSV, and influenza in all of those subpopulations listed there. And they were looking at epidemiology, vaccine effectiveness, safety. And their biggest message was that there's no emergence of any new safety signals, and that there's continued effectiveness of these vaccines. And they took all of that data, the detailed data, and they're giving it to all the societies so that the societies their members can actually review that to help with their decision-making process and making recommendations. And then the American Academy of Pediatrics. So I told you that the AAP had been sort of waiting, but doing the prep work behind the scenes during this whole year. And so then, Susan Cressley released this and said, well, kids can't wait. We're stepping up. And so the AAP has been publishing our own immunization schedule since 1934. So what we're doing now is actually not new. There's an immunization schedule that comes out every year from the AAP, and it, in the late 90s, it's we merged with the CDC so that there wouldn't be any confusion. But even then, there were some things that the AAP recommended that slightly differed from the AAP. So none of this is different than what the AAP has been doing since the 1930s. And so, last week, the AAP released the new schedule and the new revised schedule. And so we received some questions from many of you before logging in or at the time of your registration. It's, what are the health plans going to do? So the health plans, AHIP is the American Health Insurance, forgetting what the P stands for, but basically it's maybe plans. Also, all the health plans have their association that has committed to supporting vaccine access. And if you think about it, it's a very smart move by them because, of course, they're thinking about They're thinking about the patients, but they're also thinking about this from a financial standpoint. So the cost of somebody getting a vaccine preventable disease is extremely high. The cost of taking care of that person, the hospitalizations, the long-term complications, perhaps lifelong sequela, that is much more expensive than the prevention, than giving the vaccine to that individual and all the other individuals in their health plan. So it makes sense for them to want to continue coverage. And so this was back in June. They've continued to pledge a commitment. We will see about, following the release of the revised schedule, but all of the conversations have been very promising. So the Committee on Infectious Disease, I just wanted to point out a couple of people. This is the group that has been involved in the decision-making process. The person I circled there, that's Sean O'Leary. He is the chair of the COID, or it's also called the Redbook Committee. But I also wanted to point out, and he's done a huge amount of work during this year to make sure that everything's happened as it has. Many of you might recognize Mark Sawyer. He is retired from the group, but he was part of the member in 2024. There's me, and then Matt Zahn is not pictured. He's also from California, so you've got a lot of Californians represented. And during some of the decision-making process, we also had Dr. Oliver Brooks and Rob Schechter, also from California, attending those meetings. So again, great representation from California. So the AAP schedule, oops, I should have taken that, coming very soon. So it's out. It came out last week. And I will talk briefly about several of the updates. I will spend several slides on the first three there, the new recommendations for COVID-19, RSV, and HPV. So let me briefly go through the other recommendations here. So for meningococcus, there's the addition of the new pentavalent MenACWY plus B vaccine. And this is called PenMenV, and it's used very similarly as the other pentavalent vaccine that is out. And so these are all updates from the last schedule that was released in November of 2024. For influenza, there's a new recombinant influenza vaccine. It's actually not new. It had been previously approved down to 18 years, and now it's approved down to 9 years. So that's on the schedule. For hepatitis B, one of the companies discontinued their vaccine pre-Hebrio, and so that's now off of the immunization schedule. And all of the information links that are on the schedule have now been updated to trusted sources. Unfortunately, we're at a time where we're not sure that all of the CDC sites can be trusted. It's a rough time, and we all hope that that's not going to be for very long. That that it will go back to being the most trusted source. But for right now, we updated all of the links to make sure that the source is a trusted source. There are some MMWRs, those are from CDC, that have been previously published. Those are good, but everything else has been updated. So let me talk about the first three things on this list. I'll just go into a little bit more detail. So these are the considerations that we looked at for COVID-19 vaccine. So as you know, back when COVID first came out in 2020, 2021, it caused significant morbidity or mortality for all ages, but including children, especially the youngest age groups. Now we're starting to see that the epidemiology has changed. COVID has the new variants they're more easily acquired in that they can transfer from person to person more easily. However, the severity has decreased. So if you look at this chart here, so in red is COVID, in blue is influenza, just as a comparison. For influenza, we have a universal vaccination recommendation for anyone 6 months and older. If you look at this hospitalization rates, the highest hospitalizations are in those 6 months of age and younger. We don't have a vaccine for that age group, but the way to protect that age group is to vaccinate mom during pregnancy. So vaccinating the pregnant person, that the antibodies that are produced pass through the placenta and continue to protect the infant throughout their first 6 months of life. And then the next highest hospitalization rates are for those infants 6 to 23 months of age. And as you can see here, very high, similar to influenza. It starts to decrease by 2 to 4 years of age, and then much lower, 5 to 11 years, and we don't see very many at all at adolescents. And so more than half of children who are hospitalized for COVID-19 are those kids under 2 years of age. So as you can see here, the light green and the dark green. So about 50% are in that age group. And when you look at how many of those children have or don't have underlying conditions, right? Because these are the ones that we're concerned about. The underlying conditions, we already know they should get their vaccine. There's no question about that. But those without underlying conditions, if you look at, again, under 6 months of age, 71% have no underlying condition. And between 6 to 23 months, 54% have no underlying conditions. So that's quite a large percentage of people that need to be protected against COVID. From 2 to 17 years, it's about a quarter of those who have no underlying conditions who are hospitalized. And the total number of deaths. So again, here in red is COVID, blue is influenza. Under 2 years of age, COVID and influenza have very similar high numbers, number of deaths per year. This is again very recent data, July 2024 to June 2025, compared to 2 to 4 years of age and 5 to 17 years of age. And so this was the data that was evaluated and considered to make the recommendation. So the new recommendation is that we recommend universal vaccination for kids 6 to 23 months of age. Regardless of any, risk factor, healthy, it's universal vaccination for everyone. So if they're unvaccinated, they should get the primary series. If they're partially vaccinated, they should complete the primary series. And if they complete the primary series in their first year of life, then they would get updated with the COVID vaccine in year 2 of life. And it doesn't change whether or not they've had a previous COVID-19 infection. For kids 2 to 18 years of age, it's a risk-based recommendation. So the thought is that most of these children will have seen COVID at least once already, probably got infected, and therefore they've got more immunity in them once they've hit 2 years and above. And so the recommendation is to give the vaccine if your patient is high risk. So and that also includes residents of long-term care facilities or other congregate settings. Anyone who's never been vaccinated should get at least 1 dose, and persons with household contacts who are at high risk for severe COVID. And then these are the risk categories. So anyone 6 months to 23 years of age, they're considered high risk. Some of those I mentioned, and then anybody with underlying disease. And this list is not exhaustive, but you can get a sense from here. So chronic lung disease, cardiovascular disease, etc. All of that is here. Now, those who have any kind of immunosuppressive condition, it's actually recommended that they get at least 2 doses. So when you look at the vaccination schedule, you'll see the actual schedule for if they are immunocompromised and how to help them complete the primary series. For children who are between 2 to 18 years, whose parents or guardian wants them to be protected against COVID, they can receive a single dose of the COVID vaccine. And any available COVID vaccine that's approved for age and health status can be used. So currently we have the 24 to 25 vaccine that's available. The 25 to 26 vaccine is expected in September, and that should be available at your pediatrician's office, your pharmacies, and so from then they can get the 25-26 vaccine. I just have one safety slide in here because most of the safety information has not changed. COVID vaccine is extremely safe. The question has been about myocarditis following vaccine administration. And first, I want to say that the myocarditis that happens after vaccine administration is very mild compared to myocarditis that happens with COVID-19 infection. Though most of those cases with infection get hospitalized and they're hospitalized for several days and have a long-term sequela. As a complication of vaccines, most of them are treated as an outpatient, or if they're hospitalized, it's for one day and they don't have any sequela. And if you look at this data, most of that happened back here with the original monovalent vaccine, 2020 to 2022. But with the bivalent vaccine and the current vaccines that are out there, the current formulations of vaccines that are out there, we haven't really seen myocarditis as a major complication. You could see those numbers drop significantly. And so that may be something to do with the vaccine strains that are there. So, and then this slide it can be hard to look at, but here's the original strain. And then these are all the strains that have happened since. So remember early on, we knew, oh, it's Alpha, or Delta, Omicron. Now there's so many strains that we have no idea. We're way over here now. So, but just so that you understand, the current strain that's circulating is this LP 8.1 is one of the more dominant strains right now. So 2023 vaccine is that XBB 1.1.5. Then last year's vaccines, the JN1 or the KP2, and then here's the vaccine that's coming out 2025, 2026. So this is the reason why you want to be up to date with the latest vaccine that's available. So, all right, so that's COVID. Let me talk about RSV. These are much shorter, and then I'll wrap up and take questions. So with RSV, we have approval of the new long-acting monoclonal antibody clesrovimab. So this one is similar to nirsevimab in that it is long-lasting. You only need a single dose, lasts throughout the entire RSV season. For clesrovimab, it's one dose for all infants, regardless of weight, and it's just the monoclonal antibody is against different parts of the RSV fusion protein. Palivizumab was also against a fusion protein. That one is no longer going to be made. So the recommendations, clesrovimab and nirsevimab, it's the same recommendations for infants under 8 months of age born during or entering their first season. There's no preferential recommendation for one or the other. And but for the second season, only nirsevimab is recommended for children 8 to 19 months of age who are at increased risk of severe RSV disease and entering their second season. So clesrovimab does not have approval for the second season. And then palivizumab is no longer recommended. And we did receive notice from the company making palivizumab that they will no longer be making it. So, and then lastly, let me talk about HPV. So the difference between the AAP schedule and the last CDC schedule that was released in November 2024. In November 2024, that schedule says that HPV should start at 11 to 12 years of age, but it can be given at 9 years of age, or earlier, starting at 9 years of age. It sort of has that may be given, or if a child is at increased risk of HPV, such as in cases of child abuse, sexual abuse. The AAP, however, has recommended since 2000, at least the 2018 Redbook, that AAP has emphasized early initiation of the HPV series starting at age 9. It's known to be safe and effective at that early age. In fact, many of you know already, if you give the vaccine 14 years and younger, you only need 2 doses of the vaccine because of the immunogenicity. It's actually very immunogenic at the younger ages, where if you give it the vaccine 15 years and older, they need 3 doses. But at 9 years of age, it's an optimal time for acceptance and completion of the vaccination series. And this is based on multiple retrospective reviews. It's a time when you can disentangle the HPV vaccination and discussion of sexuality. Most parents aren't thinking about that yet. So when they hear about a vaccine at 9 years of age, they say, okay, sure, no problem, give it. And it also gives more opportunities for the child to come back to complete the series. Because a lot of what we have trouble with now are people initiating the series, but not completing it. They're lost to follow up after that. And then finally, for any families who want to limit the number of vaccines that are given during the adolescent platform, which is the 11, 12 years of age, giving this earlier allows them to limit the number of vaccines. That's not a safety concern or anything like that, but it is something that some parents ask about. So this is the reason. And like I said, this recommendation is actually not new. It's just now that it's part of the schedule instead of just emphasized in the Redbook. So then at the end of last week, actually on Friday, ACOG, so AAP was the first to come out with the recommendation schedule. And it's easy for AAP because we're focused on children. So on the adult side, there are many different organizations that are focused on adults. So ACOG came out with their recommendations on just this past Friday, August 22nd. And their recommendations are actually not new because they're the same as what they were last year. Based on all of the data, the safety data, the efficacy data, they continue to recommend all 3 of the respiratory virus vaccines for pregnant women: COVID-19, influenza, and RSV. The bulk of the data, and I should say this is not new and didn't come out on Friday, but Tdap is of course still recommended. The data for COVID-19 is that it not only protects the mom during pregnancy, but also protects the baby. That's a huge reason. It's actually true for all 3 of these respiratory viruses. So, and a shout out to Neil Silverman, who's at UCLA, also a Californian, who was a major part of writing up these guidelines. So, and there are additional adult guidelines coming soon. We expect this actually very soon from the ID Society of America and the American Academy of Family Physicians. So there's a lot more to come. And as you can see, all of these societies are stepping up. So what can you do? Unfortunately, it shouldn't be, but vaccines are now political. It shouldn't be, but let your senators and representatives know how your communities will be impacted, and speak out about vaccine preventable diseases and vaccines and what they could do. Remember, when you're talking with your patients, that you're still the most influential person for them to make their decisions about vaccines. You're the most common source of information. You're the most trusted source, especially for vaccine safety, and you can influence their decisions. And that's the message that we've been sending out to the public too, is, there's this questions of what immunization schedule do we follow? And we say, well, talk to your pediatrician, because the pediatricians know the best. And it's the pediatricians that made those updates to the AAP schedule. So, and let people know that your view. Social media is big now. This is our host, Eric Ball's It was on Instagram a little while ago. But speak out, speak out against those policies that seek to jeopardize that trusted relationship between you and your patient. Patients should be able to access evidence-based comprehensive medical care that's free from political interference. So be that voice for your community members, regardless of age, gender, race, or where their parents were born, because really none of that matters. We're all one community, and so our goal is to protect everyone. So with that, I thank you very much for everything that you do. There's a lot of information out there. Sometimes it's hard to know who to trust, but this is a good list. So the AAP, of course, we invite you to join the California Immunization Coalition. We need your help, especially now. The Vaccine Integrity Project is great resources. Your local epidemiologist is actually a really nice way of breaking down information. So it gives you ways of talking to your patients. So I find that to be very helpful. And the CHOP also has websites that are dedicated to how to talk to patients. So thank you.
That was fantastic. Thank you so much, Dr. Pannaraj. We only have like 5 minutes left, so we'll do some rapid fire questions. The most common question that we received was about insurance coverage. So you had mentioned that AAP and others are talking to insurance companies to try to get coverage for our commercially insured patients. As we know, VFC vaccines are linked directly to ACIP. So starting this year with COVID and potentially other vaccines in the future, do you see a potential two-tiered system with vaccine coverage between kids who are commercially insured versus kids who are on Medicaid?
Yeah, that's a great question. I think that's the one thing that we are definitely unsure about. There is a lot of advocacy going on to try to make sure that there's no, that all of this is equitable, that we want the Vaccine for Children's program, which again covers 50% of our patients, to be able to cover the vaccine for those who need it. So it's still, that's where we need all of you to get out there and make a lot of noise to make sure that those children are getting coverage.
There were some media folks on the call as well, and one of them asked if there are things that we need to really get out in the media, some messages that probably aren't out there right now. For you and I and our colleagues, this is the foremost concern of things that are going on, but there's a lot of things going on in the country and the world right now. So anything that you think needs to be better told to the general population through the media?
I think the message that we want to get across is that, we're that vaccines shouldn't be political, that we are, it's about protecting the children, the families in our community, and that the pediatricians and your providers, all providers, are the ones that really understand this process and know that. And so that to really focus on recreating that trusted partnership between the families and the providers. And so that's what I want that's what I want you all as providers to know. That's what I want the families to know. And so when at least when I'm asked in the media, I remind them that, who's the one that's been taking care of your child for their whole life? It's the pediatrician. And so they're the ones that actually know the answers regarding the vaccines.
Some people asked, the FDA had approved the Moderna vaccine for people over 65 and then people 6 months to 64 years with medical conditions, with high-risk conditions. Are those specified? Does being under 2 count as a high-risk condition? Does being pregnant count as a high-risk condition? Do we know yet?
Yeah, that's a great question. So that's one of the concerns. Well, if the Pfizer EUA doesn't get approved, and then all of a sudden we only have the Moderna vaccine, and then the Moderna vaccine is only approved for, again, those with high risk conditions, and it doesn't specify that younger age group is considered high risk. So that is a concern, but remember, it's about what is recommended and then how the insurance companies are going to cover that. So that approval process versus what the recommendation is are two different things. So the recommendation is to still give that 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 vaccine, the COVID vaccine, to anyone 6 months to 2 years of age. And I presented the data on why, because we are still seeing high hospitalization rates, high death rates, and especially in otherwise normal children in that age group.
All right, final question. I'll answer it for myself, then I'll ask you. So I will get a COVID vaccine this year, as will my wife and my children. What about you?
Yes, definitely. I will as well. And I've got kids going off to college right now. And so we'll get them their COVID vaccine. I will say, you should get anyone that's available. We are seeing a little bump in COVID right now during the summer season. But in a couple of weeks, or maybe in a week, the new 25-26 COVID vaccine will be out. So you can go get it then.
Dr. Pannaraj, thank you so much, as always, for an incredible webinar. Excellent information. Thanks for clarifying things. We will try to do these more often as things change. It's kind of hard to keep up with the changing times, but we'll try to keep you up to date. You will receive an evaluation survey, which will pop up in this webinar as soon as we are done. And then join us this Thursday, actually at noon. I will be there. California Department of Public Health and California Immunization Coalition are putting on another webinar, a similar vein, about strengthening immunization efforts, specifically with regard to the Women's, Infants, and Children, or WIC program in California. So that's at noon this Thursday. You can register using the QR code there. I think there's also information on CIC and CDPH's website. And then again, thanks for joining us for this and previous emerging conversations. You can find all our recorded previous conversations back on our YouTube page or on immunizeca.org. Again, thanks for joining. Thanks for everything you do for the people of California, and we hope to see you on the next one.
Thank you.